I said very explicitly that this is Lord of the Rings and there is one mode to rule them all, and it's APRV. Welcome to Critical Care Time, the podcast for everyone who cares for the critically ill. I'm one of your hosts, Dr. Cyrus Askin.
And I'm your other host, Dr. Nick Mark.
Sweet.
All right. We're pretty high energy today, I can see.
Yeah.
Well, we got some fun stuff. We decided to do things a little differently today, but before we get into that, obligatory what's up with you, man? You're in the process of moving, right?
Yeah, so we're moving. Our house sold today. We bought the other one a little while ago. I actually bought a new car today because I turned in my lease. Yeah, and we are flying to Canada for a wedding tomorrow. Although when our listeners hear this, the wedding will be in the rear view, of course. So lots of moving pieces, but excited to be here with you, Nick. How are things in your neck of the woods?
Oh, things are chill in my neck of the woods, man. I'm training for a big Olympic event, though. I was reading in Guinness that there is a event, the 100-meter dash, but you have to do it barefoot over Lego pieces.
God.
My kids are helping me train for this. Yeah. There's nothing like stepping on a Lego Star Wars character with lightsaber to really help you prepare for that. But the world record time is 100 meters in 24 seconds. So I feel like I got this.
That is
without the Legos, that's no problem at all. With the Legos, it adds a little bit.
I think callus is the key.
What they do that's actually sneaky is I think they break up the course. So the first 50 meters are one kind of Lego, and then they have different kinds of Legos after. So you think you're ready for it, and then it gets worse.
Oh God. What kind of masochist came up with that?
The Guinness Book of World Records, apparently. But as long as it's not General Grievous with 4 Lego lightsabers, I'm all good.
Yeah. My goodness.
So I actually, my youngest refers to him as Jennifer Grievous, not General Grievous.
I've heard that before. It makes me laugh every time I hear him say
that. He corrected me the other day. I said Jennifer Grievous and he said General Grievous. And I was a little bit sad because the era of Jennifer Grievous is also in the rear view.
But she'll always live on in our hearts.
She will. Anyway, we should probably talk about something medical while we're here.
I think that's reasonable.
What'd you have lined up for us tonight, man?
Well, so another episode where I'm kind of looking at all of the work we've done so far, and I'm like, man, how did we get to episode 60-ish and we haven't done this yet? And so you and I had been, I think, collectively kicking the can down the road on this for a while, just really trying to pursue perfection until we really finally, I think, acknowledge that perfection is the enemy of good. And so what we've done here today, I think, is put together a solidly good discussion on mechanical ventilation.
Excellent. Yeah, I think I agree with you. Perfection is the enemy of the good. There's a lot to talk about here. We could have 10 episodes and still leave important things unsaid. So I think our goal is really just to sort of build a solid foundation for listeners, with a goal of maybe really being a resource, especially for people who are newer to the topic, but hopefully maybe covering some quirks and some details that people who are experienced with mechanical ventilators may also find valuable. So listeners, don't turn this off because we said it's going to be basics. It's still going to be valuable, but just remember we're trying to be sort of a mile wide and an inch deep, not the other way around.
Yeah, and Nick and you and I have had this discussion before, where it's kind of we think of this show as a mansion. It's almost like maybe Luigi's Mansion, if you will. And as we sort of explore the mansion, and you look down a hall, it's dark. You turn on the flashlight. You finally peer down that hall, and now all of a sudden you have another avenue through which you can traverse. And so my thought with this episode is it's kind of the nexus or the gateway to further discussion, more nuanced discussions on ventilators. But, we have to start somewhere, and why not start with the basics and then some.
All right. Well, on that note, I'm going to go jump down a pipe and zoom down to the next floor, and we'll take it from there.
I guess just kind of kicking us off, as we often do, is The quintessential question here is, why do we use mechanical ventilation and what are the purposes of mechanical ventilation? And I think in my mind, I break it down into three principal purposes. Oxygenation. So essentially, as we've talked about before, we talked about this with our hypoxemia episode. Oxygen delivery is paramount in what we do. Well, it's paramount in life. And so, really, one of the goals of mechanical ventilation is to support the DO2 to VO2 ratio, making sure that there's adequate oxygen delivery. One of the other goals, kind of goal number two, is the flip side of that coin, which is really removing carbon dioxide. And we call that ventilation. And by doing so, we control the patient's pH, at least from a respiratory standpoint. Of course, can only do so much. If the patient is like profoundly metabolically deranged, we do have to acknowledge that reality, but we do what we can as far as CO2 removal. And finally, I would say airway protection is the other big reason why we will have patients on mechanical ventilation. And a good example of this would be patients that are, going to the operating room who maybe have no pulmonary disease at all, but because they're going to need to be deeply sedated and potentially, on neuromuscular blockade.
9 out of 10 patients say they'd rather be asleep for surgery. Yeah, exactly.
Sure. Yeah. So there you go. I mean, I think that's how I sort of break it down. Nick, what do you think about that?
Yeah, I think that's a great framework. So, oxygenation, our goal is delivering oxygen. Ventilation, our goal is removing CO2. And airway protection, our goal is making sure that, ventilation and oxygenation goes into the lungs and not the contents of the stomach. I think that's a great framework. I think we have to acknowledge that there are alternatives to all three of those, that it's not one size fits all. So for example, right, like there are many sort of adjacent conversations to have. Like there are other ways to give oxygen, like nasal cannula and high flow nasal cannula. There are other ways to provide ventilation, like non-invasive positive pressure ventilation. And there are other ways to protect the airway, procedures like a tracheostomy. But that's like several more episodes. We're not going to go there today. Let's not focus so much on exactly why and more sort of think about it. This is a framework for I'm looking at a patient who's intubated. Why are they intubated? It's one or more of these problems. They were either intubated for hypoxic respiratory failure, hypercarbic respiratory failure, or for airway protection, or maybe choose two or three.
Yeah, I absolutely. I think that's kind of a good ground level opening understanding of why we have patients on the ventilator. Now, I think once the patient is on the ventilator, Nick, there are certain goals that we need to kind of keep an eye on. And I think again, sticking with the concept of threes,
Hmm.
perhaps three goals to think about when a patient is intubated and on mechanical ventilation would be uh, their safety first and foremost, and so avoiding ventilator-induced lung injury. That can be pressure issues, volume issues, etc. There's the idea of patient comfort and synchrony. So really, when the patient is on the vent, one of the goals, unless and until that patient is ready to come off the vent, should be reducing work of breathing. And also trying to avoid dysynchrony, which will likely mention dysynchrony from time to time and kind of paint with broad strokes here. But I think ventilator dysynchrony is another episode, if not two episodes down the road. And then the last thing I'll say, I kind of alluded to this before, is this idea of once the patient is ready to come off the vent, and we do want them to work a little bit, we do want to see what they're capable of. That's the idea of facilitating recovery and weaning. And our readiness assessments, things like that, which we did touch on in our extubation episode from a little while ago. Nick, anything else you'd want to add on those fronts?
I think it's to our credit that we had an episode on getting somebody off the ventilator before we talked about the ventilator. I think that's priorities. But yes,
I
I
love
agree
that.
with that. I agree with that framework. So number one, safety. We want to ventilate somebody in a way that's safe. Um, I'll give a little spoiler here and say that one of my favorite rules, shout out to Dr. Trish Critic for teaching me this, is the best mode is the mode that everyone understands.
Yeah.
Right. So we all have to have a shared mental model about what we're doing and what the settings are and stuff like that. So safety, goal number one. Comfort and synchrony, goal number two. I think often we choose bad settings on the ventilator, and that leads us to have to use a lot of medication. I think if we choose good settings on the ventilator, in many cases, patients require minimal or in some case no sedation. So I think that's another really core pillar of mechanical ventilation. And then finally, facilitating weaning or liberation from the ventilator is really important. important. And I think that, there are choices that you can make that perhaps can make this worse. And I don't know, maybe there are choices that can make this better. But I think,
Right.
I think the goal here is to be aggressive about intubating people when they need it, but also aggressive about extubating people when they no longer need it. And as we said in that episode, if I'm not reintubating, I'm probably not extubating enough. So you need to be equally aggressive about getting tubes out of people as in.
I love it, Nick. And I think, I I wanted to have you maybe walk us through in some more detail the concepts of ventilation and oxygenation. But before we do that, one thing that you said that I think really rings true, and it's a recurring theme whenever I talk to trainees about this is you're right. This isn't Lord of the Rings. There is not one ring to rule them all here. There's not one ventilator mode to rule them all. Many of us like assist control, volume control, or ACVC. We lean on that mode. We see that mode often in the hospital, but there are certainly times when that's maybe not the best decision. And so we'll start disambiguating some of this and demystifying some of this. But that's a really important point, Nick, about kind of just you got to pick the mode that everyone on the team understands and the mode that works with the patient and their condition in the most optimal way.
And maybe one other thing that I'll say before we get a little more in the details. This is another quote that I use a lot. This is from Michael Lewis' Moneyball, which is a
Yeah.
fantastic book. Um, every strength is a weakness and every weakness is a strength. And I think, when you're choosing stuff about a ventilator, when you're choosing a setting, when you're choosing a mode, when you're doing things like that, there's always trade-offs. And I think you should always think about, what am I trading? Right. We'll talk more about this when we talk about pressure and volume and flow versus pressure triggers and all these places where these trade-offs occur. But I think, really important concept, when you're thinking about ventilators is like, what's a strength of this option and what's a weakness? And, maybe that weakness is actually a strength in the right person and vice versa.
Beautiful. All right, so let's peel back another layer of this onion and talk a little bit about ventilation, oxygenation in some more granularity. So when you try to break those down, maybe for a trainee, how do you approach that?
Yeah, so I think what you said before is great. I mean, the idea that ventilation is about CO2 removal. This depends fundamentally on your minute ventilation. Your minute ventilation, remember, is like the cardiac output of the lungs, right? Your cardiac output is your heart rate times your stroke volume. Your minute ventilation is your respiratory rate times your tidal volume. And the idea here is really simple. Larger volumes delivered more often will give you more ventilation. More ventilation will get rid of more CO2. This will raise your pH. That's all you really have to understand about ventilation.
Yep.
Now, oxygenation is a little bit more nuanced. There's a little bit more going on here. Obviously, our goal is to get an adequate amount of oxygen into the person. I say adequate, I don't mean perfect. I don't mean your PaO2 has to be like 105, like mine is right now. Like, I'll settle for a lower number. I'll settle for a SAT of 89, 90 in many cases. It doesn't have to be perfect, but it has to be enough. You mentioned this before, the idea of maintaining an adequate DO2 to match their VO2. That's the goal here. Now, the key determinant of how much oxygen gets from the ventilator into your body is this concept of mean airway pressure and FiO2. So the FiO2 is easy. That's what fraction of the air is oxygen, right? All of us right now are breathing, presumably, 21% oxygen, and the rest is mostly nitrogen with a teensy bit of argon in there, right? If we want to give somebody more oxygen, we can just turn that number up. Unfortunately, that number only goes up to 100. And so if we really want to get more oxygen into somebody, we have to raise the pressure in the alveoli to push more of it into the bloodstream. And the key determinants here are basically like, how high is the pressure and how often is it high, right? So
Hmm.
the higher your peak pressures, good. The higher your PEEP, your positive ended expiratory pressure, good. And the more time you're spending at that higher pressure are really the determinants of mean airway pressure, which is really the key determinant of your oxygen delivery. That sounds complicated. It's a little bit complicated. I think if you see a formula for it and if you think about it, it's really actually quite straightforward, just like minute ventilation. I also think a lot of this will make more sense when we talk about actual modes. Some of this is hard in theory and easy in practice.
I agree. So kind of in keeping with that, I think peeling back another layer, some of the terminology we should probably review now because it's likely to come up again, if not in this episode, in subsequent episodes that we do on ventilators. So I think first thing to think about is this idea of a trigger. So the trigger is really
Mm,
what is going to initiate the breath. And in broad strokes, you can think of it as time versus patient effort. So, for example, just to make things easy, because I'm a simple man, let's say that you have a patient with a respiratory rate of 10. That means that every 6 seconds, essentially, there's a 6 second countdown, and every 6 seconds, a breath will be delivered. That would be the trigger. That is a time trigger. Whereas in an assisted mode, or in a we'll just say in an assisted mode, the patient's effort will actually trigger the ventilator to provide them assistance based upon whatever parameters you've dialed in. So that patient effort can be based upon change in pressure. It can be changed, in changes in flow. So kind of again, patient effort. And sometimes even, I have not used one of these myself, but there are tools like the Nava device where basically the contraction of the diaphragm is perceived through electrical activity. So basically, the phrenic nerve essentially tells the ventilator, "Hey, I'm trying to breathe," and then the ventilator delivers a breath. And so, I'll pause there as far as trigger goes. Nick, anything else you wanted to add?
I think that's perfect. I mean, trigger is what's initiating the breath. Like you said, there's control modes where essentially the ventilator is doing it, and the concept there is it's basically a timer, right? If you haven't taken a breath in X seconds, it's going to do it for you. And then the other idea are these assist modes where it's waiting for the patient to do something to say, "Hey, I'm taking a breath here," and then give you help. And like you said, it could be either a pressure trigger or a flow trigger, or in some cases, NAVA, which is a neurally adjusted ventilatory assist mode. Essentially, it's sensing electrical activity in the diaphragm, just like you said. It's a mode I don't reach for very often, quite frankly. I think in the pediatric world, they like that mode more. I'll say one more comment about trigger, which is that this is a good example of that Michael Lewis rule, which is that in general, the flow trigger is more sensitive, which is good. But because it's more sensitive, it's more likely to auto trigger or trigger erroneously, which is bad. Its strength is also a weakness. Sometimes when you're having trouble with it, you want to choose a trigger which is less sensitive, like a pressure trigger. The patient will have to work more to get the breath started, but it's less likely to fire erroneously. So its weakness is its strength.
Well put, Nick. So moving on, a couple other terms that we need to talk about. So cycle is essentially when does the breath end? And so that could be based on time, flow, or volume. Essentially, whatever the cycle is, basically ensures that the patient has been given the appropriate amount of air, again, based on what was dialed in. So a good example would be in let's say in a volume control mode where every breath is delivered, a certain volume is dialed in to be given X number of times. Once that volume has gone from ventilator into patient, the breath is complete. And that's essentially the cycle in that circumstance.
Right. In contrast, like in pressure control, it's time cycled, which basically means that it goes to a certain pressure and delivers that pressure for a certain amount of time, and then it says, "Okay, I'm done," and stops. Um, Another option is the flow trigger, which is basically this idea that once the flow has decreased, kind of at the end of a breath, it's like, "Okay, we're done here." And you might see this in like a pressure support mode. I think this is something that gives people a lot of confusion if you're not like a biomedical engineer or like kind of person. But I think, once you've played around with this a little bit, it kind of makes sense. Like, how does the ventilator know when it's reached its goal? Right? Is it volume cycled? Is it time cycled? Is it flow cycled? These terms start to make sense after you've thought about these modes a little, and almost never on the first time through, by the way.
So, like you're saying, we're talking about things like pressure and volume. There's another term that kind of relates to both of those concepts, which is the idea of a limit. And so, for example, let's say you have someone with very, very sick lungs. We talked about ARDS in a previous episode. The one of the hallmarks of ARDS is reduced lung compliance, which essentially manifests as volume is delivered, massive pressure change relative to norm, right? And so we talked earlier, albeit briefly, about the idea of barotrauma. And so, how do we prevent that from happening in this case that I just outlined? Well, you have a limit. So, I, let's say, decide, oh, I'm going to give this patient a tidal volume of 600, which is a pretty high tidal volume for a lot of our patients in the medical ICU, especially. But I'm going to give them this tidal volume of 600. But I'm also going to set a pressure limit to where the pressure is not going to exceed such and such a value. What that means is that the ventilator is going to give the breath, it's going to attempt, shall we say, to give 600, but it may only give 200 because it has hit that pressure limit that is going to stop the breath. It's essentially going to, you can almost think of it as prematurely cycling the breath. It's preventing the entire breath from being delivered because that limit was reached.
Exactly. Yeah. I think sometimes people get confused about the difference between limit and cycle. In many cases, they're actually the same. I
Mhm.
think one thing to understand about limit is you can actually have multiple limits, and the ventilator has some hard stops built into it. Like there's a valve that won't let you exceed a certain pressure, right? It's a little bit different than the concept of cycling, where it's trying to reach a goal. Limit, it's like, you can be volume cycled and volume limited, but you could also be pressure limited. And there's often sort of backup modes too, where like let's say that a ventilator is like giving a breath and like it's waiting for the flow to drop off. Like it won't just give that breath forever. It's not I mean, ventilators actually are pretty stupid, but they're not this stupid that it will just give a
Right.
breath forever, right? It's a little bit smarter than that. At least the modern ones are.
So continuing on, there's these terms that are again confusing, but there's this idea
Mhm.
of assist versus control, and we also have
Which you actually kind of explained already, but you should say it again.
yeah, I want to make sure that I'm clear here because we'll often talk about modes that incorporate both an assist element and a control element.
Yep.
But in a let's say a sort of draconian control mode, essentially the ventilator is going to initiate its breath based on a fixed schedule and or a set respiratory rate. So I'm gonna, I want the respiratory rate to be 12. I want the patient to get a tidal volume of 400. And so that's what the patient is going to get, assuming they don't hit their limit. So let's say that this person has the healthiest lungs in the world and they can totally tolerate that 400 of tidal volume. They're going to get 400 cc's and it's going to happen 12 times in a minute. If this is strictly a control mode, then the patient's efforts are not actually going to be reciprocated in any way. So they're just going to get what is dialed in. Now, we, at least where how I practice and what I've seen and what I've done,
Here in the 21st century where we practice and not the 20th century where these modes were
right,
invented.
we actually utilize a little bit of a hybrid, which is this idea of assist control, volume control, for example, or assist control, pressure control. And again, we're going to disambiguate this further. But in an assist mode, the patient gets support whenever they attempt to initiate a breath, depending on what type of support that is, whether that's a volume assist or a pressure assist. It depends on the mode. But that would be like a good example of that might be a patient who is breathing, who is intubated but breathing spontaneously completely. You may use an entirely assist driven mode. We call that, for example, a pressure support mode. That's another term, and I know it gets a bit confusing, but that's a mode where the patient is getting assistance or support, but there isn't like a X number of breaths that are going to be given at such and such an interval. And then to make things even a little more confusing is what I was getting at before, which is this idea of the common mode that we see, this ACVC, where not only does the patient have these breaths that are kind of mandatory based on the respiratory rate, but should the patient attempt to draw breath, let's say in between some of those mandatory breaths, they will get a fully assisted breath in this particular case. So they will get support based on how you set up the ventilator. Hopefully, that's about as clear as mud.
Yeah, I think a lot of the terminology is confusing because the tech used to be way worse than it is now. So, like, if back in the 1960s when they built these things, it was essentially just a timer. So you set the rate. Let's say you set a rate of 12, and that meant that every 5 seconds it was going to try to give you a breath. So it was basically just a timer that counted to five and then gave a breath. And if you took any extra breaths in there, didn't care. Not listening to you, not doing anything with you. That was the purely control mode. Patients obviously hated that. That's super uncomfortable. So then they invented this idea where, like, oh, actually, we'll let you take a breath, and actually, we'll be a little flexible about that timing. So, like, we care that you're getting the right number of breaths in a minute. But if you just took a breath like 1 second ago, we're not going to immediately jam another breath into you. And that's why sometimes you see this, like, assist control mode where it's kind of two things in one, even though you would really never use a pure control mode anymore. I mean, you could, like somebody in the operating room, they might use this mode where they're not going to be breathing spontaneously. But in the intensive care unit, we're almost always going to use an assist control mode because that's sort of like what the defaults are.
Perfect. Perfect. So now that we've hopefully not lost too many people with that, and I think it'll be a little clearer when you go through the vent modes themselves. Um, but the sort of last concept, that's a lie. The next concept that I kind of wanted to touch on would be pressures as measurements, I guess you could say, or pressures that we really need
Yeah.
to know about. And the two main pressures here would be peak and plateau. And yes, there are certainly other pressures that are important, but I think again, this being a ventilators 101 intro to ventilators, I really want to try to focus on peak and plateau because if you get that, then I think you're on your way. And so, Nick, I'm curious to know how you sort of teach this, but in my mind, I think of the peak pressure as relating to airway resistance. And it's really that the highest pressure that you see during the breath. And in large part, it's kind of, uh, I think of the peak pressures as being determined almost by like starting from the ventilator all the way down to sort of the conducting airways. And it's that I think of it almost as one long tube and many different things can impact that tube. So, for example, if it is the actual endotracheal tube that we're talking about, and the patient is biting down on that tube, or that tube has significant mucus impaction, that is going to increase the resistance. And therefore, the ventilator is going to need to overcome that resistance to try to deliver the breath. And so that's what you're going to pick up on when you're looking at the vent. You're going to see that elevated peak pressure, indicative of the fact that there's something between the vent and those terminal bronchioles that is requiring a higher peak pressure than what you'd expect. And then the other side of that coin is this idea of plateau pressure. And I don't know. I've kind of probably adopted this bad habit of referring to it as such, but I think of it as like this is the pressure that the alveoli are sort of seeing once the pressure has sort of equilibrated throughout the system. So once you've delivered the enough of a breath to overcome that resistance, and so you've had your peak, you then have a sort of pressure that a resulting pressure, which is really what is that out? What it's sort of representative of the alveolar pressure, which in turn could be thought of as a surrogate for compliance. Again, that idea of delta V over delta P, change in volume over change in pressure. And very quickly stated, when we see increases in the plateau pressure, and maybe Nick, you can remind us how we get a plateau pressure, but when we see increases in the plateau pressure, that we can think of as a compliance problem. That we can often think of as a parenchymal problem or something that is extrinsic to the lung parenchyma, but is still causing effective loss of alveolar volume. And so, an example of that, before I kind of hand it over to you, Nick, would be abdominal compartment syndrome, which you'd think of maybe intrinsically as a resistance problem, but really what's happening is as the abdominal pressure is increasing, it's it's impairing diaphragmatic excursion. It's reducing your effective alveolar volume.
Yeah, yeah. So, okay, there's a lot here. So
There's a
let's
lot.
let me back up for a second, and we'll talk about this concept of how you measure a plateau pressure, because I think that's illustrative. So you go into a room and it's going beep 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 beep. The machine is upset, and it says that the pressure is high, right? Well, you don't really know what the problem is. You don't know, is that a resistance problem? Is that there's something, there's mucus in the tube, they're biting the tube is kinked? Is it a problem with limiting resistance because there's like an obstruction in their trachea? Is it a problem in the bronchioles, bronchi, etc.? You don't know where the problem is, right? You don't know whether it's a resistance problem or a compliance problem. So what you need to do to sort this out is something called an inspiratory hold maneuver. And what this is you walk up to the machine and you press inspiratory hold. So what does the machine do? There's two valves inside the ventilator. There's one that opens at the beginning of the breath and air blows in. And then once the breath is delivered, that valve closes. Now, normally, the expiratory valve opens immediately and the air starts coming back out, right? That's the immediate transition from inspiration to expiration. When you press the inspiratory hold button, what happens is it doesn't open the expiratory valve. So essentially, it gave a breath and then it stopped giving the breath, but it didn't let you breathe out. So now what happens is flow stops and you're at rest, and you can kind of see what the pressure is in the lungs when you're not flowing. And so the idea here is, if this was a resistance problem, if you had a narrowing somewhere that was making it hard to get air in, your compliance is normal. So once the breath stops, your plateau pressure, where the pressure equilibrates, is going to be normal, right? So when you see a high peak and a normal plateau, that's a resistance problem, right? And like you said, anywhere from the ventilator tubing, endotracheal tube, airways, down to the alveoli is where that could be. It could be bronchoconstriction, could be mucus plugging, could be an obstruction, etc. The other possibility is maybe this is a compliance problem, and you mentioned some issues there. So maybe the issue is that you've got a big pneumothorax, maybe you've got a big pleural effusion and one lung is really collapsed and you're trying to give two lungs volume into one lung. Maybe it's an abdominal problem. Maybe it's a chest wall problem. Maybe this person is having like fentanyl rigid chest syndrome and they just can't expand their chest. There's a lot of things that it could be. The value of the inspiratory hold maneuver is it will tell you, is this a peak problem, which is indicative of resistance, or is this a plateau problem, which is indicative of compliance, just like you said.
Excellent. A great explanation. I think the way that I have to shout out to a friend and colleague, mentor of mine, Tyson Shulin, who's in San Antonio, who, when he kind of teaches this, I've stolen it shamelessly. Uh, Resistance problems are an RT problem. Plateau issues are a doctor problem. And what he means by that, and because we love our RTs, so it's not at all meant to sound disparaging. What he means by that is, when you have resistance issues, typically that's something that your RT can investigate or they can fix based upon a simple order. It's a bite block. It is a kink in the tubing that just needs to be replaced. It is passing that inline suction. It is giving a bronchodilator. Plateau problems, on the other hand, are often okay. We need to sit down and actually think what has changed here, if anything. The person's plateau pressures might be high right off the bat. And just for some context, historically, we think of a plateau pressure of greater than 30 in ARDS as being not tolerable, or not acceptable, I should say, and greater than 40 for peak pressures as being, kind of the upper limit of what we're willing to accept. And so in the case of plateau pressures, it might be like, okay, well, this person needs a needle either to drain that pleural effusion or that pneumothorax that Nick alluded to, or maybe this patient needs more aggressive diuresis, or they need steroids or something like that for their ARDS. That's kind of the mnemonic that I use to keep these two straight.
Yeah, I think that's a great framework for it. I mean, I think I should say we'll have a infographic for this on the website. So there's more if you want to look at more, and you should look at more. This is just a normal part of assessing somebody on the ventilator too. It's not just a maneuver you do when somebody's alarming. Measuring the plateau pressure is something you should be doing frequently anyway. So frequently when I'm rounding on a patient, this is something I'm just checking. It's also good to have a baseline. I always get into the habit of checking what the peak pressure is and what the plateau pressure is before I do any procedures in
Yep.
the neck or the chest. Just because if you cause a pneumo, you know, it's nice that you could spot that earlier potentially. I will say I've never caused a pneumo with a central line, but someday I might,
Oh, wow.
and I'll
No, I have, so
and I'll,
lucky
I'll
you.
catch it earlier because I do this thing. But I mean, it's just a matter of time, right? I mean, these things happen. But the point is that like it's a data point. You want to have this data when you're in the room of a patient on mechanical ventilation. Your physical exam is more than just the patient. Your physical exam includes all the machines attached to the patient, and one of those things you have to examine is the ventilator. And part of that exam is measuring a plateau pressure because it gives you really useful information to know what is their baseline resistance and compliance.
So at this point, just to kind of recap, we've talked about why we use mechanical ventilation. We talked about our goals. Why we talked about oxygenation, ventilation, airway protection, goals. We talked about safety, patient comfort, and getting that patient off the ventilator as being a goal. Obviously, we don't want them to be on the ventilator forever. We broke down oxygenation and ventilation into things like minute ventilation, into things like the mean airway pressure, the FiO2, and then we've just finished talking about several terms, things like trigger, limit, so on and so forth, as well as, of course, our peak and plateau pressures.
I think we should talk about I think we should just talk about modes now, frankly. I think we've built the framework we need.
I think so. I think when we as maybe just a point of orientation as we get into our modes, you're going to hear us talking about FiO2, PEEP or positive end expiratory pressure,
Hmm.
tidal volume, respiratory rate, inspiratory pressure, inspiratory time. A lot of these are things we have already talked about, and actually the nomenclature is not too bad here. I'll say PEEP. We think of again that positive end expiratory pressure is sort of the pressure that is continuously provided, so to speak, to the patient to sort of stent the distal airways open and also prevent atelectasis. So, one of the traumas that we think about in the world of ventilators is attelect trauma, the idea of airways opening and closing repeatedly. Exactly right. I like that little sound effect. And so PEEP helps us prevent that. And it also does functionally increase the mean airway pressure, not surprisingly. So the higher that PEEP is, the higher the mean airway pressure is going to be. But yeah, I think outside of that, we probably are ready to talk about modes, unless you have anything else, Nick.
One other thing I'll say, so whenever I'm teaching like a med student or a resident in the ICU, we always talk about vent stuff early on. And then the sort of homework assignment thereafter is to know every patient's ventilator modes. And I think when you're learning this for the first time, it's like a lot of numbers, right? And I think, the trick that really helps people is to group them, right? It's kind of like most people don't remember a 10-digit number very well, but almost everyone can remember a phone number if you use parentheses around the area code and a little hyphen in between the first three and the last four. Sorry to our international listeners who have weird phone numbers. But the idea applies here as well, right? Which is that, like, if you want to think about all these numbers, you should group them thematically. And so, what I always tell people to do is to sort of map the settings onto the physiologic parameter you're thinking about. So, for example, and you said this exactly, Cyrus, when you're thinking about FiO2 and PEEP, those are your oxygenation variables, right? Group those together. When you're thinking about things like in volume control, respiratory rate, and tidal volume, those are ventilation parameters. Group those together. There's nothing that's like more confusing to me is when somebody's presenting a patient and they tell me these things in a weird order, because like that's not the way my brain thinks, right? It would be like getting the area code last. That's just not how we're expecting the information. And so, what I like to do is I like to have people sort of map it onto the blood gas too. So they think like, okay, the PaO2 is whatever, and then here's the FiO2 and the PEEP that go with that. The pH and the PCO2 are here, and here's the respiratory rate and tidal volume that go with that. On the infographic on our website, they're color coded blue and green, so it makes it a little easier to see that. But I just would encourage you to think about it that way too, because it reduces the number of objects you have to keep in your working memory a bit, and it just makes it easier to organize your thoughts.
All right. So now the time has come for us to actually talk about ventilator modes. I feel like we've been teasing this for the last, 30 to 40 minutes, but I also think you got to have a good foundation.
So people stuck with us this long. Should we just tell them what the best mode is and just stop?
Yes, exactly. Because I said very explicitly that this is Lord of the Rings, and there is one mode to rule them all, and it's APRV.
Exactly. Yes, and there are people who genuinely think that, and that is terrifying. Yeah.
And we'll play that game a little bit in a little while, but no. So truthfully, there really isn't one mode to rule them all. The mode, and Nick, I think you really said this quite well. Um, it's got to be the mode that makes sense for your institution, for the folks that are going to be coming on shift, coming off shift, that are going to kind of be able to easily, seamlessly pick up on the strategy that you've set forth for that patient. And it also has to be a mode that works for the patient. And there are definitely times when you have to color outside the lines a little bit. You know, there are times when I put patients on a spontaneous mode who normally would be, you know, at least by the textbook, better suited on an ACVC or something like that, and so on and so forth. So with that, maybe we can, you know, get into some of the modes, and starting with volume control. We can talk about that one first.
Yeah, and I think, we should maybe acknowledge one thing, which is that this is sort of like, part of the country thinks in hemoglobin and part of the country thinks in hematocrit. Some places are sort of pressure control shops and some places are more volume control shops.
It's a great point.
You know, I neither one is superior to the other. There's pros and cons to each, strengths and weaknesses, et cetera. I think it's important to understand all the modes, but I think it's really important to understand the modes that your institution uses. Like you said, Cyrus, like, there's a lot of matching modes to patients, but like, unless you plan to stay at the patient's bedside 24/7 to like make sure that those modes are followed faithfully, you got to use something that everybody else is going to understand. So if you're going to deviate from your kind of norms, you should do it for a good reason and you should make sure you sign that out carefully to people. There's nothing worse than like rounding and discovering that somebody's on like some bizarro mode for no reason.
Right. Okay, great. So maybe I'll tackle the first one, and we'll
Go
talk
for it.
about I've always called it ACVC, maybe because the band, I don't know.
By the
But
way, we got some swag in our critical care store, including that t-shirt. So yeah.
Oh, yes, beautiful. Yeah, so I need to get myself one of those. So ACVC, assist control volume control. Essentially, what we're doing is we are inputting a respiratory rate and a tidal volume, and there's going to be a PEEP and an FiO2. And so conceptually, it's pretty easy for us to wrap our head around that. They're going to get a minute ventilation based upon that, the product of the respiratory rate and the volume. And their oxygenation is going to be supported by a combination of FiO2 and their PEEP. Again, PEEP kind of you could think of PEEP, higher PEEP as being increasing that mean airway pressure. And so what's going to happen is essentially it is a volume cycled mode. So once the patient has gotten the volume that you have dialed in, that will terminate the breath. It's also a pressure limited mode because if the patient, let's say, like in the previous example, has very poorly compliant lungs, very, very poor lung compliance, you may try to deliver that volume, but because of the limits that are set, that volume may, or excuse me, that breath may be terminated, quote unquote, prematurely because further breath, so to speak, would exceed your pressure limit.
Now, just an important caveat there is that usually that sort of hard stop pressure limit is quite high. So you
Right.
really don't want to rely on that number to protect them. That's going to be like a super high number, like 50. So don't use the pop off valve to protect the patient's lungs. That's your job as the intensivist.
Yes. Yeah. So really, I think what that kind of gets to is that you need to be mindful of your patient's physiology and pathophysiology when you're determining the volumes you want to try to deliver. And one important point here, and I'm almost surprised we didn't get to this yet, is when you put the patient on the ventilator and you sort of choose the mode that you think is appropriate, you don't sort of like set it and run away. You really need to set the ventilator in the way that you think is appropriate and watch the vent, look at the scalars. And we haven't really talked a lot about scalars, basically the graphics that are generated. We're going to talk about that at another time. But basically, you can look at the data that the ventilator is giving you, look at the patient, look at how they're breathing, and and use that really to help you decide, at least initially, what kind of adjustments you want to make. To your point, Nick, you don't want to just use that pressure security blanket and be like, it's fine, whatever. You really should be mindful about the settings.
I like to always say, like, okay, I changed something. Are they ventilating? Are they oxygenating? Are they safe? Are they comfortable? Right? Sort of run through those, because sometimes you maybe you did something that was well intentioned. You made some number a little bit better, but now they're like wildly desynchronous. They're double stacking. You made everything way worse. So don't run away. Go back. A lot of machines have a previous settings, like an undo button. So when you do
Right.
something stupid, you can just go revert to your prior settings that maybe were better. Yeah, I think important caveat. And then obviously, depending on your institution, like where I work, the RTs are perfectly comfortable with me changing stuff on the ventilator. At some places, you will get murdered if you do that. So you should sort of like respect your institutional norms and, in some cases, and for good reason, right? I mean, really only people who are very familiar with the unit should be changing buttons on it, right? But respect those norms if you want to keep your hands.
I think that's a good point. And I'll say too, as shout out to our respiratory therapists, they're really the boots on the ground when it comes to the, hour to hour adjustments to the ventilators. And so it's very understandable why, if you're going to make changes to the vent, it's just kind of professional courtesy, and it's also good for the patient, it's good for the team to let that respiratory therapist know, hey, this is what I'm thinking. This is what I did. This is why I did it. What do you think? Because I'll be honest, like I consider myself an expert in pulmonary and critical care medicine, but when it comes to this particular ventilator that happens to be, what this particular patient is on, it's entirely possible that that respiratory therapist with 10, 15, 20 years of experience knows that particular ventilator a little bit better than I do. And they can often provide some very useful insights. And so it's a collaborative approach to these patients.
Absolutely, yeah. I mean, in my shop, we have a couple different models of ventilator that we use, and there's a lot of little nuance. Like, does this mode have this feature? No. Oh, it does, but it's called this. So really, the RTs are your friends. Like, this is really you should be adjusting it with them, have them teach you as you're doing it,
Mhm.
and also, kind of show them what you're trying to do, as opposed to just like sneaking into rooms and turning knobs.
Yes.
That's definitely not the
Suboptimal.
walk away from this episode.
No, it's a good way to lose friends.
Yeah, and fingers. One thing we should probably say for each mode, I like to sort of think about like what are the settings for this mode. And so for volume control, like what are the things that you have to specify? I think of it as like sort of four big things, and there's a couple minor things we don't have to really get into. So the big things are your rate, how often, your tidal volume, how much, your PEEP, what's the pressure in between breaths, and the FiO2, right?
Mhm.
So two ventilation parameters, two oxygenation parameters. There are a couple minor parameters that are actually worth touching on for just a second. So there's this thing called the inspiratory flow rate, or V dot, which basically determines how quickly it's going to give the breath in. The reason why this is important is kind of two situations. Number one is sometimes the patient may be experiencing air hunger. They feel like they're not getting enough from the ventilator. And sometimes by either giving them the air more quickly so they feel more forceful inspiration, or sometimes giving it to them more slowly so they feel the effects of it more gradually, you can increase comfort. So that's a good reason to fiddle with the inspiratory flow rate, or V dot. Another reason is that sometimes when you're ventilating somebody a lot, and you really need to get a lot of minute ventilation into them, you have to deliver breaths quickly. And so by increasing the inspiratory flow rate, you can reduce your I time and give them more time to exhale. So the inspiratory flow rate is kind of a minor setting, but in the right setting, super, super useful.
Great point.
The other sort of minor setting that is really valuable, and not every machine can do this, by the way, is this idea of an inspiratory hold time. So remember I said that the ventilator gives you a breath, and then the inspiratory valve closes and the expiratory valve opens right away, and then the air comes out. So you basically go inspiration, expiration, inspiration, expiration. Well, some ventilators have this option where they can give you a breath and then kind of hang out for a beat and then open the expiratory valve.
Yep.
Why would you ever want to do this? This only makes your IDE worse. Well, there's one situation which is useful, which is kind of that air hunger situation. Maybe it's worth pausing for a second and saying, like, how do we feel like we've gotten enough air? Like when I take a deep breath, like, how do I know, like, oh, that was a deep breath? Well, it turns out there's a couple of things you're doing. Your brain's kind of integrating a couple inputs. You're feeling the airflow in your nose and your mouth. You're feeling it in your vocal cords, your trachea. So you're feeling air moving in, but you're also getting stretch, right? You're also sort of feeling your chest expand and you're feeling in your intercostal muscles stretch receptors activate. And so, in order for those to fully register, sometimes it takes a little time. And so, sometimes if somebody is air hungry, if you give them a little bit of inspiratory hold time, they feel way better. Doesn't always work. Maybe one time in 10, it works
Mhm.
miraculously. And then it's a great fix. The alternative being like heavily sedate this person who's desynchronous. And all you do is you turn one knob, and then everybody's like, wow, that's amazing.
Excellent. Kind of just rounding out our discussion on ACVC or VCAC, depending on, which terminology you prefer. Uh, Really, the good thing, or the pro, if you will, as it relates to this mode, is it really does guarantee that tidal volume, which in turn gives you kind of a guaranteed minute ventilation, more or less. Now, of course, if the patient is breathing above the sort of set rate, they're going to have a greater minute ventilation. But you do, as Nick alluded to, run the risk of that patient entering into desynchrony, just kind of depending on a number of factors. We'll get into that in another episode. I don't want to bog us down too much here, but essentially you get that guaranteed tidal volume or that guaranteed minute ventilation. It's sort of the ventilator mode that was studied in the ORMA trial. It's kind of
Yep.
the one that is classically used in ARDS. It's probably the one that we understand the best, so to speak. But you do need to watch out for barotrauma, especially in those folks. We talked about this in the ARDS episode, but who suffer from that baby lung physiology. So people who have very, very reduced effective alveolar volume, you can't just deliver them a tidal volume of 4 or 500 and walk away from the ventilator. Those are people who are not likely to do well, and so that's where you can run into issues.
Perfect. Great summary of volume control. I'll just say volume control, probably the most commonly used mode in most institutions, in most adult ICUs. Your mileage may vary. In the peds world, it's different. Some institutions really like pressure. So this is not one size fits all, but this is a good mode to get comfortable with, including the nuances.
Nick, you mentioned pressure. Maybe we can talk about ACPC now.
Yeah. So pressure control is kind of the opposite story. So in volume control, what we were doing is we were saying, give this much volume this often. In pressure control, we're saying, give this much pressure for this long this often. And so technically, this is a pressure targeted time cycled mode. What that means is that it hits a target pressure and keeps giving that much pressure for a while. And then when it hits a certain amount of time, the inspiratory time, it says stop. So, for example, it might give you 25 centimeters of water for 1 second. This is really good because it ensures that your pressure can't be more than that goal. The problem is your volume is anyone's guess. That's going to depend on your compliance. And that's not just a lung issue, that's also a patient compliance issue. Like what are you reacting to this with? If you're sucking in a big breath, right? It's going to give you a lot more volume. If you're fighting it, it's going to give you a little tiny volume. So in volume control, we had to worry, are we giving this person too much pressure? In pressure control, we have to worry, are we giving this person too much or too little volume? So it's kind of like pick your poison. What are you ensuring that the ventilator is going to do? And what are you kind of you have to check and verify and keep going back to make sure it's okay.
Yeah, I like how you describe that. I think we didn't mention this term specifically, but in you can compare and contrast in ACVC, the pressure is really the dependent variable. And the independent variables are the various things you dial in that we talked about, things like volume, respiratory rate. In ACPC, it's that volume that is going to be the dependent variable, and it's going to vary from breath to breath, and it's going to be a function of those independent variables, things like inspiratory pressure, inspiratory time, so on and so forth.
Exactly. So just to run through the settings on this one, you've got your rate, your inspiratory pressure, and your inspiratory time. So you have three variables that are going to determine ventilation. And then for oxygenation, you've got PEEP and FiO2. There's also, this is kind of like the equivalent of the inspiratory flow rate. There's this idea of rise time, which is basically how quickly does it get to that goal pressure. The idea is it's not like, when you fill up the tires in your car, it's not like instantly full pressure. The ventilator's a little gentle, right? So it doesn't go all the way up to full pressure instantly. It kind of rises over a certain amount of time. So rise time is sort of the analogous thing there, where if you set a shorter rise time, it will reach pressure faster and it will give you a better IDE. Conversely, that's pretty uncomfortable. We don't want to breathe from those like tire pump things. So
Right.
you might want to set it a little longer to make the patient a little more comfortable.
Excellent. And I think, just kind of to round this one out, your pros and cons for this ventilator mode. It can be a useful option when you have very poor compliance, so quote unquote stiff lungs. But the, the thing is, I'm almost hesitant to say that because it's more of like, what alarm do you care more or less about? Which one pisses you off more? And how are you going to end around it? It's kind of like, okay, yeah, I can put someone on AC PC and the machine will alarm a lot less from a pressure standpoint. In fact, it won't alarm at all from a pressure standpoint. But their tidal volume is now 30 cc's. And so they're essentially only aerating their trachea. And so you're going to get the low minute ventilation alarms going off. And the same thing, kind of the reverse is true for your volume control mode, where it's like, yeah, I can try to deliver these volumes, but I'm going to hit my limits or I'm going to have alarm issues all day long. And so it just recognize that changing the ventilator mode doesn't change the patient's pathophysiology. Like you have to treat the patient and their underlying disease. And the ventilator is just a supportive tool to get you from point A to point B.
Right, exactly. Your strengths are your weaknesses are your strengths. So, understand the strengths and weaknesses of these two. There's a couple of times that I kind of reach for this mode. One situation is desperation. Like I've tried all the tricks that I know and they don't like volume control. So sometimes I'm like, maybe this person will just like pressure control better. And there are physiologic reasons why some people really do. Volume control, depending on how you set it exactly, the flow is very kind of either constant or it's got a very mechanical decelerating waveform. In pressure control, the flow tends to be more dynamic. That's a little bit more like how you and I are breathing right now. So some people like that better and they're just more comfortable. They're more synchronous. So that's potentially a reason. Like try it. They love it. Okay. Recognize I'm going to have to do things differently. The other situation where I kind of like it is like, let's say you've got a patient on ECMO where you're ventilating them, but you're really not relying on the ventilator to provide, CO2 removal. So you don't really care if they have hypoventilation. What you're really trying to do is you're really trying to let them breathe and you're trying to avoid barotrauma. This is a great mode there because it just won't exceed the target pressure. So I really like it in those two settings in particular.
That's a really good point. Yeah, I remember we'd often do like the 10-10-10 kind of initial mode where you have like
Mm.
you know
Rate of
a
10, inspiratory
rate of
pressure 10,
10
peak of 10.
people. Yes, yeah,
Yeah.
exactly, and kind of start there, and then
Yep.
you could wiggle around a bit and easy to remember, and
Yeah.
sort of got the job done.
This is like who is that pizza guy who got killed, who died of COVID at a Trump rally? Herman Cain, the
Yes, yeah,
555 deal. Yeah.
yeah,
This is
yeah.
this is the 10-10-10 deal.
The 10-10-10 deal. Okay, so moving on because we still have a few modes that we want to talk about here. There's one of my sort of like favorite modes, but also potentially problematic modes is PRVC or VC plus. PRVC stands for pressure regulated volume control. So essentially, what we're doing, we're combining aspects of pressure control with volume control. So the breaths are delivered at a certain pressure, but there is a tidal volume that is targeted. It's kind of a volume guarantee. So to break that down a bit further, essentially what the ventilator is doing is it's automatically adjusting the inspiratory pressure on a breath to breath basis or so to achieve the set tidal volume.
And one little detail here. So essentially, you're setting two pressures. You're setting kind of
Right.
what's the lowest acceptable and what's the highest acceptable, and it's going to basically target a tidal volume that you also specify, and it's going to adjust. And it's not adjusting like breath to breath. It's adjusting like during the breath. So like 100 times per second, it's adjusting the pressure to try to get to that volume goal. So if the other modes are dumb, this mode is smart but
It
sometimes
is
it's a little
smart.
too smart, and that can be a problem as we'll get to.
That's exactly right. So another thing you see this with a few different ventilator modes. We talk about like a decelerating waveform
Mm,
in terms of the pattern with which flow is delivered, and really the thought there is that might be more comfortable for the patient. So we often think of this pressure regulated volume control or VC plus, depending on the brand of ventilator you use. We think of it as a more comfortable mode for the patient because the breaths can vary. You're really like it's very adaptive. You've got your hard left and your hard right, but ideally, what the machine is going to do is it's going to provide the targeted volume with kind of the least amount of pressure necessary to achieve the targeted volume. And so then there's this idea of the flow pattern, which is basically, when you or I breathe, and this is probably true for our listeners as well. We don't just
hopefully.
go from like 0 to 60 instantly. You initiate your breath with kind of more flow, and towards the top of your breath, that flow drops off. And that's the idea of a decelerating pattern, which is supposed to be more physiologic. In like straight up VC, just a volume control mode, you essentially have a square wave form of flow, unless you've adjusted it otherwise, to where you basically go from no flow to all the flow to no flow to all the flow. And so really, why is that helpful? That can help with synchrony and comfort because flow is initially high when demand is the greatest, and then it decreases as that inspiratory drive wanes. Um, and so, with that being said, Nick, maybe you can walk us through the settings kind of crystal clear before you get to pros and cons.
Yeah, so think of this mode as like fancy pantsy volume control on the user interface side, but actually what it's doing on the patient side, what's doing under the hood with the algorithm is more pressure control. So it's
Love
really a
it.
pressure mode that's hitting a volume goal. So what do you set? You set a respiratory rate and you set a tidal volume goal. You also tell it a P max. How much is too much? And then you set for oxygenation, you set an FiO2 and a PEEP, just like on all the other modes. There are some other settings under the hood. I'm actually not going to get into those now. I think this deserves more time if we're going to talk about those. But the key idea here, and I think this sort of sums up everything we're going to say about this, is the good thing about PRVC is the more work you do, the less it helps you. The
Yep.
bad thing about PRVC is the more work you do, the less it helps you. And so
Amen.
its strengths really are its weaknesses, and its weaknesses really are its strengths.
It's an excellent point. So you basically what you mean by that, I think to say it another way is in patients who you're concerned for kind of higher work of breathing, and how that could be injurious. So again, your ARDS patients, um, the what can happen is that the ventilator may actually reduce support because it's interpreting that patient's kind of increased respiratory effort as overachievement of the target, so to speak. So they get more volume than the machine means to deliver, and so then the machine will, to the best of its ability, based on the information it's collecting, will reduce its support, and then that reduction in support can sort of paradoxically increase patient effort further, and so it can kind of put you in this vicious cycle. And so my sort of takeaway is that I like PRVC a lot in folks that aren't being intubated for ARDS and don't have, significant severe lung disease. So, an example might be your septic patient for whom you're just like intubating them for to try to help better manage their acid base status, but you're not as worried about what they're doing on a breath to breath basis. Or certainly, like maybe a better example would be in your surgical ICU. I really like this in surgical ICUs where their lungs, for all intents and purposes, are fine. They just had like a traumatic amputation, and so PRVC may be a good mode for that. And that's kind of how I use it and how I've liked it.
Yeah, I think, actually one as a side note, I think everybody should have the experience of breathing all these different modes themselves on a ventilator. And I'm not proposing that you go out and get yourself intubated. You can
Fair.
usually work it out with your RT that you could try these modes. And the way you do this is you put on nose plugs and you just put the tube in your mouth. and you just breathe through it like it's a snorkel essentially. And it's really interesting to try the different modes and feel what they're like. Uh, you'll very quickly determine what you hate, and you might determine what you like, but you'll really figure out what you hate. And most of the time when I've done this, or when I've walked other people through this, people like PRBC because you feel like you're in control, right?
Mhm.
Like you initiate the breath when you want to, and you kind of determine how much force you're going to do, and it just backs you up a little bit. It's kind of nice in that sense. The problem is that's like a healthy person. If you're like sick, if you're like gasping, the harder you work, the less it's going to help you. And so you get into this spiral of you work hard, it helps you less. You work harder, it helps you less. And so this is a terrible mode in anyone with respiratory distress. It's an okay mode in everybody else. And sometimes for comfort reasons, it's the best mode.
Yep.
I think we tend to use this mode too much, at least in my shop. This tends to be a default. And just like you said, Cyrus, like for patients where you're really trying to strictly control what's going on, a strict control mode like assist control volume control, assist control pressure control are probably the better and certainly better studied modes for those situations.
And just before we get to the next mode, that's a great point on how it's sort of the default in your shop, Nick, because it is in ours as well. And the problem is because of the brand of ventilator that many of our folks are on, it just shows up as ACVC plus. And so the
Mm,
trainees just report it as ACVC. They don't really pay any attention to that plus sign. And invariably, it's like my sort of
completely different
evergreen,
mode. Exactly.
it's
Yeah.
a totally different mode. And so it's like my
Yeah.
discussion every week I'm on service is like, okay, so you said they're on ACVC. Are they really on ACVC? Let's walk over and look at oh, look at that plus sign. What do you think about that plus sign? And all of a sudden it's like, oh, I guess this is an entirely different vent mode. And I had no idea.
Yeah.
So um moving on, so we can get to some of the other vent modes here. We'll sort of like pivot to one that's fairly straightforward. You can think of it as invasive bilevel. I hate saying that, but that's kind of in essence what we're doing with pressure support mode. In pressure support mode, the patient is triggering the breaths. So the patient attempts to breathe. They get a breath that is supported based upon the amount of support you've dialed in. And there is not a respiratory rate per se. There is generally an apnea mode or an apnea sort of failsafe to where if the patient doesn't breathe, they will switch over. They'll get a breath, and then the machine will switch them over to a controlled setting. But essentially, with pressure support, the patient is dictating a lot of the ebbs and flows of their breathing pattern.
Yeah, I think we're not talking about scalars, right? And what you see, but one of the clues about pressure support is every breath is going to look different, right? The idea
Right.
here is the patient's fully in control. They're kind of telling the machine how much they want. If we're going to be technical about this, this is a flow cycled pressure limited mode. What the heck does that mean? What that means is that basically the machine is going to start giving you a breath, and then it's going to keep giving you a certain amount of pressure support, a certain pressure is going to be held until your flow drops off. And what you could think about this is like, if you're filling up a balloon, let's say, and you're blowing into it, first it's filling up a lot and you're getting a lot of flow. But then as it gets full, the flow is going to drop off. That's essentially what this is doing here. It's basically saying once you're starting to get full and your flows start to drop off, it's going to stop. Now, there are some situations where this doesn't work super well. Like famously, like if somebody has like big pneumothorax with a huge air leak into their chest tube, the flow might continue for a really long time. So they might have some issues with breath termination. I think that's probably more of like that's a fun edge case, but it's rarely important. I think the bigger issue with this mode is the patient has to do all the work, right?
Right.
And so you have to give them enough pressure support to help them. And sometimes what happens is we choose too low a number. We put somebody on like a spontaneous breathing trial type settings, like 5 of pressure support over 5 of PEEP, and that's not enough, and they look terrible right away. Right? Sometimes people need a lot of pressure support if you're going to use this mode. And so, if you're going to use it, don't be afraid to give them a fair amount of support and then let them do it for many hours.
Yeah, I think that's a really important point. There is that just because it's a spontaneous mode doesn't mean it can't be a very supportive mode. I mean, support's in the name. So I like it. Uh, don't be scared of giving them a lot of support. If if you feel like that's the appropriate mode for the patient and they're tolerating it well, so long as they have the appropriate amount of support, great. Classically, where we see this mode is towards the end of a patient's course when we're doing our spontaneous awakening and spontaneous breathing trials. And we talked in our extubation episode about different strategies there. And sometimes you'll see patients put on pressure support for longer periods of time if for whatever reason you feel that they need a longer sort of period of vent liberation, i.e., a so-called weaning. I don't even know what to call it. Like they need a prolonged wean. Uh, Now that gets kind of controversial to a certain degree, and it really does depend on the patient's underlying physiology. But we'll talk a little bit more about that idea of weaning as we continue.
Yeah, I think let's leave it there on pressure support. There's obviously deeper conversations to be had, but we've got at least two more modes to talk about. So let's move
Yes.
on to the next one.
All right, Nick. Well, this might be our bone of contention, our first one in three
Yeah.
seasons. Why don't you tell me, Nick, about the flip phone of ventilation?
Yeah. So the that old thick, stupid Nokia phone that weighs 12 pounds. Well, he's referring to synchronized intermittent mandatory ventilation, or SIMV. So SIMV is kind of an old school mode. It used to be more popular. Basically, the idea is that when you're on like a volume control or a pressure control mode, if you trigger the ventilator, you get a breath, just like if it triggers the ventilator. Every breath looks the same, whether you start it or the machine starts it. SIMV is a little different. It's kind of like the machine breaths are going to look one way and your breaths are going to look different. So if you're on the receiving end of this, which I have been, it feels a little weird. You kind of don't know what you're going to expect. You know, it's kind of like that Forrest Gump, like life is a box of chocolates. Well, there's just like weird, sour, like, gummy bears thrown in there. Like, this is a weird mode because you think you're in control. And then all of a sudden you get this big, forceful machine breath. And then you think you're in control. And then you get this big machine breath. So that is why this mode is largely fallen out of style, out of use, because for people who are more awake, it's not necessarily more comfortable. In the old days, they used to think that this was a quote weaning mode because the idea was that you would start off and you would have the machine provide more support and you would just do a little. And then over time, you would sort of turn down the machine support so the patient would have to do more. Turns out that doesn't work as a strategy. You just don't get stronger like that. That's part of why we don't call it weaning anymore. We like to call it more like liberation because it's really about when are you ready. It's not about like getting you slowly off the ventilator. I guess one other thing to say about this is sometimes you'll see these sort of interesting hybrid modes where it'll be like SIMV plus pressure support. So it'll sort of support your breaths with a little pressure support. And then it'll give you a mandatory number of machine breaths too. Sometimes people like that. There's really only two situations where I go for this mode. Every other situation is probably unnecessary. The one situation where I like it is the person who has a really high respiratory drive, right? So, like for example, you've got somebody who's got liver disease where their liver isn't metabolizing estrogen and progesterone, and those are respiratory stimulants. I think the progesterone really, and they're going to have a higher respiratory rate. They're probably going to have a mild respiratory alkalosis at baseline. But then you put them on the ventilator and you're like, oh no, they're breathing like 35 times a minute. And you get their blood gas and their pH is like 7.7. You're like, oh my God, what do I do? Right. And you turn down the rate and it doesn't work because they're over breathing the ventilator. Right. So it's a hard problem. Like, what do you do about this? Do you just like deeply sedate them? Well, that's kind of a lame solution. Is there a better way? Yes. SIMV can be useful in this setting because often the breaths that they're taking are really small and then the machine breaths are like a little bit larger. So if you use SIMV in people with really high drive because of like liver disease, sometimes you can get to the sweet spot where their pH is normal. They're getting the number of breaths they want, but they're not getting these massive 500 mil breaths like they would if they were on volume control or PRBC. So that's one case. There's one other case where I absolutely love SIMV, which is hiccups, right?
Hmm.
So hiccups here, like I've never had hiccups on the ventilator before. I haven't managed to capture that moment. But anyone who's had hiccups knows they suck, right? And just imagine that every time you hiccup, you're getting like 500 mils blown in your lungs. That would be really terrible, right? This is a really deeply uncomfortable thing. And you might just be like, well, why don't you just turn down the ventilator? Like, why don't you just make it so it's not going off every time? Well, the answer is you really can't. If you turn the pressure or flow trigger sensitivities like as low as they'll possibly go, so they're like not sensitive, a hiccup will still trigger them 100% of the time. A hiccup has got enough airflow and enough pressure that the ventilator is going to be just like going gangbusters on them. So what you really want to do in these patients is you really want to just limit the volume they're getting with these hiccups, because every time they trigger with a hiccup, they'll just get a little bit of air and then they'll stop the flow and they won't get a huge volume. So those are the two times that I still like this mode, right? Hiccups and high respiratory drive. Other than that, consign it to the waste bin of history. I agree with you. But
Okay.
those are the two cases I have for it.
Fair. Okay. So not as this isn't like your go-to. This isn't your one ring to rule them all, which is what I was concerned about. Okay.
No, 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 no.
Uh
I almost never use this mode. Usually, if I see somebody on this mode, I'm like, why are they on this mode? But there are a few times when this mode is actually still useful. And so, if we have to
right.
pay more to keep this mode on whatever new ventilators we get, I'm going to insist that we do because it's useful sometimes.
So and I'll kind of support uh your point here. So the hiccups thing I haven't really thought about, but that's a really great point. I think and then my typical go-to with the respiratory alkalosis situation is I typically will add tubing to the ventilator.
Yeah. So that's another really elegant solution, right? Yeah. You could just add dead space and let them rebreathe a little
Exactly.
CO2.
Increase their dead
That works
space.
too.
So I'll do that. And then I have used SIMV with some modicum of success in the neuro ICU with patients who have like high spinal cord injuries, and you're
Mm,
really doing like a very slow wean. Again, I don't know what other term. I hate to use I don't want people to take away from this episode that we're weaning everyone over days and
yeah.
days. But sometimes you do have patients who need a long time to come off the vent or to figure out whether they're going to be able to come off the vent. And SIMV can be helpful for that because you can basically decrease the number of mandatory breaths per minute. And also, you can decrease or increase the support that the patient gets for any of those patient triggered breaths as the patient kind of evolves.
That's a great point, and I'll add one little detail on there, which is I really want to emphasize that your ventilator modes have to fit the patient and the
Yep.
illness. And so high spinal cord injury is kind of a unique case. Remember I said that, like, how do we know we've gotten enough air? And some of it has to do with like feeling stretch in our intercostal muscles through these J receptors, whatever. Well, if you have a high spinal cord injury, you're no longer getting that neural input from your intercostal muscles. So you don't get that feeling of like, I got enough air. There's got to be a better word for this, but I think of it as like air satiety. Like, I got
Yeah.
enough breath. Like, you're not getting that signal. So you feel really weird, right? So sometimes people who are chronically mechanically ventilated because of a high spinal cord injury will be on weird looking settings. They'll be on like a rate of 6 and
Yes.
like a liter of tidal volume. Part of the reason why they're on that is because their lungs are totally healthy and it's not injuring them. This is like the settings they're on at home. So we don't have to put them on lung protective settings. They're fine with those volumes. But the reason why they like those volumes is because they're not getting all that stretch input. So they need more volume to feel air satiated. So that can be appropriate. Obviously, don't use that in ARDS. That's probably too much.
Yep.
But in people who are coming off the street with something else who have a home ventilator, that may be appropriate for this reason.
So to sort of like finish the discussion on SIMV, I think why so once again I thought maybe we were going to have more of a disagreement here, but I think we actually generally agree.
I think I sold you on hiccups, right?
You sold me
You're
on
gonna try it now on
hiccups.
hiccups. Yeah.
You sold me on hiccups. I'll say that in general, SIMV is kind of built for a problem that we don't really like believe in anymore, in the sense that
Right.
um, we don't we don't need to solve how do we wean patients? We basically treat them until they don't need to be treated anymore, and then we start to do our SBTs and try to get them off the ventilator. And in fact, uh, despite what we were doing in the 70s and 80s, the more recent evidence that we have suggests that this actually delays the goal, which is liberation from the vent.
Precisely.
We know that in broad strokes, SIMV doesn't change outcomes. It does not improve mortality or ventilator free days. Like I said, it actually often will prolong ventilator days. To that extent, you can actually see it create problems as opposed to solving them, because you can have, uh, you know, potentially some synchrony issues, but also higher sedation needs can arise if you're doing this for long periods of time.
Just remember, if you're on the receiving end of it, it feels weird. Like, you're
Yeah,
just like, "Whoa, what was that?" "Oh, normal breath, normal breath. Whoa,
it's
what was that?"
and yeah, and the last thing I'll say, I think that I think is a good point is, for me, PRVC is the mode that I would go to 99 times out of 100 over SIMV. Now I realize that they're not totally analogous, but and they're not analogous. But if you have a patient who's appropriate for SIMV, that means that the patient it should mean that the patient doesn't have ARDS. And so if that's the case, then generally speaking, based on the modicum of data that we have, I think PRVC is a fine mode and probably a very worthwhile trial
Or
as
just
opposed to some of the other
vanilla
modes.
volume control or pressure
Sure,
control, frankly. I mean, yeah,
absolutely.
like, this mode is rarely the right mode, except for the times that it's great. Bottom line.
Now pivoting to a mode that's always the right mode,
Why don't
APRV.
you sell me on why this is the best mode ever?
Oh, okay, all right. So I'm not going to be able to do that because I don't. I'm really being very tongue in
Do you want
cheek
me to?
here.
Actually, I can steel man this, even though I don't believe it.
I can give it a shot. I can kind of tell you
Okay.
why I used it in the past, and
Why
then
don't
I'm
you tell us
curious to
about the
hear.
mode, and then I'll make the pro case, and you can make the con case. How about that?
Love it. So essentially, what is APRV? APRV stands for airway pressure release ventilation. You can think of it as, and I feel like I'll get vilified by the pulmonary community for saying, you can think of it as invasive CPAP with breaks, with intermittent releases. So essentially, um, most of the cycle is spent at a high pressure. We call that the P high. And then every so often, there'll be a short, significant drop in pressure down to the P low. So the terms we think of are the T high and the T low. So that would be the time spent at the high pressure versus the low pressure. And of course, we have a P high and a P low, which is what the pressures are. And then you have like the number of times the essentially the respiratory rate, which is like the number of times the patient has that T low. And you can also, of course, set your FiO2. And so the idea here, and why it can be a compelling option, is it gets back to what Nick was talking about when he discussed mean airway pressure. So it's like if if mean airway pressure is directly associated with alveolar oxygenation, then wouldn't it be nice if we had a ventilator mode that heavily indexed on that concept? And that is APRV. But we can't just have them on like 30 centimeters of water ad infinitum. We have to give the patient an opportunity to have a release, which is when theoretically the lion's share of their ventilation occurs. Now, there's some thought that there's passive diffusion of CO2 that occurs even at the P high, but the conventional wisdom would suggest that the big release that happens every so often is really when they're able to ventilate. And so that sort of uh, obviously sets the stage for a mode that's pretty effective for oxygenation, but fairly questionable from a ventilatory standpoint, which depending on the patient, and this is, I guess I'll hand this off to you in just a second, Nick. But if you have a patient who has plenty of pH and we really it's like early in their course of ARDS, they don't have right heart failure, and you're willing to accept that hypercapnia, i.e., permissive hypercapnia, and you're trying to prevent them from going on to ECMO or something like that, then certainly, at least on paper, it's worth a try. Now, granted, we have things like prone positioning and parsimonious fluids, and so like other things that we do in ARDS that have a much stronger evidentiary base. But that's kind of like my 10,000-foot view on APRV, trying to leave something on the table for you, Nick. So take it away.
Yeah, okay, okay. Listening to you talk, it was very hard to stick to the I'm gonna sell the pros because I really vehemently want to like condemn all the problems with it. But let's try. So exactly what you said. This is, all about mean airway pressure, right? And you can think about this as being an inverse ratio ventilation mode. So normally we spend more time in exhalation than in inhalation. APRV, you spend more time in inhalation and short, brief times in exhalation. And the idea there is your mean airway pressure is higher, so you're pushing more oxygen into the alveoli and into the lungs and into the bloodstream. That's great. The studies suggest that you have slightly better oxygenation with this mode compared to other modes. The other really good selling point for this mode, I think, is this idea that patients are more comfortable because they can breathe up and down around that high pressure, right?
Absolutely. Yeah.
And so theoretically, this might be more comfortable for some set of patients because even though they're getting this crazy high pressure and it's inverse ratio and it feels super weird and terrible, maybe they're a little more comfortable because they can sort of be in control. That's a nice idea. I'm going to switch to the cons now. So the cons are the difference in oxygenation is pretty marginal, and there's better things you can do to improve oxygenation. So if you want to remove oxygen consumption, you could give neuromuscular blockers. If you want to improve the which areas of the lungs are ventilated and oxygenated, you could prone them. If you are really hypoxic, you should probably be thinking about, is this an ECMO candidate? There's a lot of other things to do other than APRV, is my point. And if you end up doing those things, then APRV becomes unnecessary, right? If the person is deeply sedated and on neuromuscular blockers, they don't need this comfort mode. Just use a safe, regular mode. If somebody's on ECMO, don't use this crazy mode. Use really safe, like 10-10-10, like settings like you were talking about, right? So that the use case is one issue. Another issue that I sort of take issue with here is like, well, actually, one huge problem is when you walk in and somebody is sedated on Nimbex and APRV, and it's like
Yep.
completely unnecessary. End the APRV right now. The other issue, going back to what I said earlier, is this idea of, like simplicity is good, or the best mode is the mode that we all understand. And I think there are a couple sort of dangerous mistakes you can make with this mode. If you have the P low too long, you can de-recruit and you can get atelect trauma. And so you can cause a lot of ventilator induced lung injury with this. Uh, if the person is not comfortable on this mode, you can end up deeply sedating them. And then what was the point of all this? Because you're maintaining a very high mean airway pressure, the mechanical power delivered to the lungs is very high, which we know is potentially injurious in ARDS. And because the pressures are relatively high, we know there's potentially a risk of like air trapping, volume trauma, barotrauma, et cetera. So like this mode, if you find just the right patient, might be okay, but usually there's a better thing to do, is kind of how I would bottom line it. I'm reminded, and maybe this is the problem with us recording late at night as we're doing tonight, but like, I'm reminded of this kind of irrelevant Mark Twain quote where he said that a cauliflower is nothing but a cabbage with a college education. I feel like APRV is nothing but inverse ratio ventilation with a college education. Like it's just a fancy way of doing something that we could do with a simpler, safer mode anyway. And the use case for it is really narrow. Somebody who's not an ECMO candidate, somebody who's only comfortable on this mode where you've tried everything else. Sure, that sounds great. Let's give it a go. But it's rare in my experience.
I think I would love to just moderate a future episode between you and like an APRV like bro, yeah, aficionado, mastermind, guru, whatever. And just kind of like I think it would be really fun to explore because I mean, I think 99% of the time I would agree with you. I mean, I think the fringe cases exist where it's like, well, this person's not going to be an ECMO candidate. Um, I'm catching them early in their course. They still have some recruitable lung that maybe I could get to with APRV. They've got plenty of room to go on their CO2. no RV failure.
This is exactly a conversation I had on a podcast at the very beginning of COVID. I was talking to somebody in a surgical ICU, surgical intensivist, who was a big believer in this. And that's
Mhm.
basically what their argument was, which was that like everybody in this ICU is totally comfortable with this mode. Nobody is confused by it. We don't have any ECMO circuits. It's, it's New York City COVID. Like, come on, man. And many of our patients need this because they're uncomfortable on everything else. And I was like, well, why aren't you proning them? That was sort of where the conversation ended.
Right.
But I mean, I I'm not saying this mode has no uses. I think kind of like SIMB, it's useful in your armamentarium, but the use case is narrow, and I think the risks are very real. And I think it only takes one person who misunderstands a mode and changes the settings or doesn't catch that there's a problem for the small benefit of APRV over like a conventional inverse ratio to become a huge harm. So that's kind of my case, but I would love to argue this with somebody else. So listeners, if you are incensed by what I just said, please write to us, Cyrus at Critical Care Time, and we'd love to hear from you.
All right. So, guys, thanks for bearing with us so far. I know we covered a lot of what I think is pretty high yield introductory material to ventilators. Maybe finishing out here might be just taking a few moments to go over some safety considerations and pitfalls, pitfalls and pearls. I think first and foremost, we say this often in medicine: do no harm, right? Um, sometimes medicine's a contact sport, and harm does occur. But we should at least endeavor not to cause harm. And when it comes to ventilators, that means things like barotrauma, volutrauma, adlect trauma. We didn't really talk about biotrauma here, because but those three kind of primary traumas, I think, are the ones that we, from a ventilator standpoint, we can really mitigate. The other kind of, I guess, pitfalls that I'll talk about briefly here, and then Nick, I'll turn it over to you, would be the idea of trying to chase numbers. Now, I've certainly been guilty of saying on rounds, sometimes you just have to try to make the patient euboxic, and hope that that gets you to the goal. And sometimes that's true, when the fog of war is particularly thick. But generally speaking, when it comes to ventilators, we can be a lot more nuanced. So things like the risks of hyperoxygenation, permissive hypercapnia, recognizing again that perfection is the enemy of good. Um, those are things I think are important to kind of keep in mind, uh, both as a trainee or early career physician, or really anyone who's working with ventilators. Nick, why don't you take it away? I've talked enough now. What else would you add?
Yeah, I think you hit some good points, which is that, that there's really an important thing we have to do, which is minimizing the harm of the ventilator. Some of that is the patient can get the ventilator to hurt them. So, for example, if the patient is triggering the ventilator and they're double stacking breaths, or they're sort of not ventilating appropriately, that's one sort of harm. Another harm is where like we're just being unreasonable in our goals, as you said. So, like trying to target life supporting but not necessarily perfect blue box numbers is also important. So, and I think the other thing is just being very aware of what your ventilator is doing. So like when I'm rounding on patients, right, I'm writing down like what are the vent settings, what is the blood gas, and what are the values that those vent settings are causing. So for example, like what is the plateau pressure, what is the peak pressure, what's the compliance, etc. And so I kind of have the full picture, and I could be like, all right, do we really need it to be set that way? Can we adjust it? Because it's a lot of small adjustments to sort of bring people into an acceptable range to minimize those traumas you talked about. I think, another thing that a mistake that people tend to make is we tend to fixate on the FiO2 knob instead of the PEEP knob in hypoxia. And I think sometimes PEEP is the better option. Whenever you walk in a room and you see a patient who's on a PEEP of 5 and 100% FiO2, kind of like, well, what's going on here? Because usually somebody who's that hypoxic that they need that much FiO2 probably needs more PEEP. And maybe this wasn't done in the most rational way. So I think that's an important thing to look for, that sort of discrepancy.
I agree with all that, and I think really at the end of the day, we've said this a few times now, you just really need to look at your patient, consider the goals that you're trying to achieve, and really just tie in the settings on the ventilator with patient centered physiologic goals that get you from point A to point B.
I think that's a great summary. I think the other thing that I see sometimes is like a failure of imagination that like, sometimes everybody's on the same settings and some people are like really uncomfortable or deeply sedated because they're uncomfortable. And that's kind of a failure of imagination, right? Like what that person needs is to like try out some different things and see if something else is better. Like the same way I say, like, if you're not re-intubating, you're not extubating enough. If every single person is on the same vent settings, you're probably not thinking about the ventilator enough because I guarantee you all the people in your ICU are not the same. And they may all be fine on those settings, but sometimes there's somebody where you could be doing a better job by adjusting the ventilator instead of adjusting the sedation. And so it's often something that you as a physician in concert with your RT, concert with your critical care nurse can adjust together and you can really see the improvement. And the benefits are huge, right? Like you get people off sedation, you wake them up, they come off the ventilator sooner, they mobilize sooner, like everything goes better just by making a couple little changes. Maybe you switch the mode, you switch a couple settings around. Like you could just do a lot with a little with the ventilator.
All right, folks. So I know this was a longer episode, but it's hard to kind of lay the foundations for ventilators in a short period of time and do the topic justice. Uh, I like to think we did that. Hopefully, you guys will agree. Please let us know. But really, in broad strokes, I think that's exactly what we did. We talked about why we use mechanical ventilation, what our goals are. We talked about some of the terms, the definitions, parameters, and then we really got into the modes and had, I think, a nice little back and forth discussion about why certain modes might be a good option. What are the pitfalls? What are the pearls? Some of our perspectives from our own experience and admittedly our own biases. And then, yeah, I think we kind of just now finished out with overall some pitfalls and pearls approach to mechanical ventilation, and really have now set the stage for some very exciting discussions I look forward to in the future. Nick, this was a lot of fun. I hope you had a good time talking about this
Yeah,
too.
this was great. I mean, I think, I kind of come from a technical background and I think sometimes like this is a scary topic for me to talk about because I want to talk about everything. And I think,
Yeah.
don't worry, there's a lot more we could say. There's more details. Don't worry, it's coming. But I think this is a really good foundation, especially for people new to the ICU who are intimidated by what is that box with that tube stuck in the patient's mouth. Like this episode's for you, but I think we can build on this and we can add a lot of nuance. Plus, I have all these like fun animal ventilator things we didn't even get to talk about today. So obviously we have to do another ventilator episode so we can talk about dolphin and elephant and mouse ventilators, some of which I've actually.
And so while you guys are waiting with bated breath for the release of those episodes, if you want to learn more about this topic or other topics, please go to our website, www.criticalcaretime.com, where we have our show notes, infographics, calculators, and of course the store too. Nick's actually sporting one of our new shirts. You may recognize the logo. I certainly don't. Just kidding. But yes,
Yeah.
go there,
Hopefully,
grab some
hopefully
swag.
no one else will, so we won't get sued. But it says
Right.
the Nor Epi with
Yes.
a not North Face, but sort of like North Face logo. Anyway, there's a
Perfect.
lot of funny swag in our store now. I want
Absolutely.
to say a big thanks to the people who have shopped in our store. You guys are great. Also, the people who have left us comments, people who have shared the show with others. If you're enjoying this show, please send it to your group chat, send it to your residency buds, send it to your nursing school buds. Like help other people find us because we're always trying to reach more people. We're also greatly appreciative of our editors who make us sound smart, everyone who contributes to the production of the show, all the many things that go into pre and post, folks over at Podpaste. Big thanks to Kurt Belknap for the theme music you're hearing now. Yeah, and we want to hear from you. So keep your feedback coming. If you're mad, Cyrus at criticalcaretime.com.
Hmm.
If you have nice things to say, you can tweet or X at us or whatever, at CritCareTime, at Nick M. Mark, at Askins_Razor. We're also on Threads, Blue Sky, Instagram, YouTube, etc. We read all your comments. Even if we don't respond right away, we save them up. excitedly.
We do. We do. And yes, definitely Nick needs all that positive reinforcement. He's a very fragile ego. So
That's right.
So with that kind of quick disclaimers, I don't really think we talked about any cases. So I don't think we need to worry about that. But what I will say is that our podcast is for educational and entertainment purposes only. It should not be used in lieu of seeking medical advice. And of course, the opinions that we expressed here are not necessarily the opinions of our employers. So keep that in mind when you listen to us. With all of that, thank you guys so much for listening and for being really the best part of what we do.
It's been fun.
Motivating us to record. For me, it's 11 o'clock at night that we're finishing this up. So thank you guys so much. I'm Dr. Cyrus Askin. So long.
And I'm Dr. Nick Mark. See you all next time.